Okay, so good morning, Nurse Smith, and good morning, students. We're going to be doing the NCD program and NCDs in general this morning. So without any further ado, I'd like to welcome Nurse Barsha Smith, who is the Program Manager for NCDs at the Department of Public Health and Ministry of Health. Thank you. Welcome, Nurse Smith. Good morning.
Good morning, and happy to be here. Happy to see everyone. Please permit me to share my screen with you. Can everyone see my screen okay?
Good morning. Yes, ma'am.
Okay, awesome. So good morning again. I'm so happy to be here. I'm Nurse Barsha Smith, a registered nurse. Recently deployed to the chronic non-communicable diseases section as of July 26th. So this is a relatively new area, a new assignment for me, and I am happy to be a part of CNCD. So the objectives for today is to provide an overview of the CNCD program, to identify the 4 main categories of CNCD, to identify the risk factors associated with CNCDs, and to explain diabetes, hypertension, and asthma guidelines. We'll also be looking at some of the complications of CNCD. We'll focus a little bit on the diabetic foot assessment, and we'll also be looking at screening and interviewing protocols for the clients with CNCD. I believe that together, and you could tell me if you also agree, I believe that together, which is us at CNCD, each of you, that we all can prevent CNCDs. Do you think that's possible? I also believe that if we identify the risk factors early, then we are able to provide better management for those with CNCDs. And that together we can provide the quality of care, the highest quality of care for individuals with CNCD. The CNCD team is very small. It consists of myself, Nurse Barsha Smith, Nurse Tania Lang Brown, Nurse LaFleur, Nurse Kemp, Nurse Swaby, Nurse Johnson, and of course, at each clinic in New Providence and the Family Islands, we have a CNCD clinic coordinator. There are some clinics that maybe have more than one CNCD clinic coordinator. What is the goal of the CNCD program? Well, I consider CNCD to be the heartbeat of public health. And the reason I say that is because we are responsible for strengthening the response to chronic non-communicable diseases such as asthma, hypertension, and diabetes. And that is our number one mortality. So when we strengthen our response, we are able to prevent, reduce, and delay morbidity. So we delay persons dying younger, and we improve their quality of life, their mortality and morbidity, sorry. So we allow them to live longer and healthier and have a better quality of life. Our aim is to monitor and evaluate all the activities at the health clinic. And when we say health clinic, we're talking about clinics in New Providence and the Family Islands. And every activities that is done at the clinic that relates to CNCD, we monitor those. We also audit files of the clients in the clinic as a way of monitoring what happens to these patients. Once we collect the information though, we don't just store it or put it down or file a report. It is for us to interpret our findings and then put in place measures to correct any challenges that we face. Our objectives, we identify clients with risk factors for CNCD, and I'm going to talk about those risk factors in a few more minutes. We look at preventive care, improve access to preventative care, because we know public health is about prevention. We also look at the treatment. Is the treatment that we are providing to these patients effective? We also look at how can we decrease the risk factors for CNCD through behavioral modification and lifestyle changes. We also, at CNCD, our objective is to ensure that we have training like this one to provide healthcare workers with the knowledge and skills to be able to manage patients that have CNCDs. We also continue to increase the awareness of the community in the prevention of CNCDs. We monitor and evaluate compliance with the protocol, and that is done through our biannual audit. And we also look at the development and implementation of additional protocol as it relates to asthma, diabetes, and hypertension. We will also be looking at some of the health forms and tools that we use at CNCD, and we ensure that at the clinic, all CNCD tasks are carried out. We also, when we do our audits at the clinic, we will look at what's happening at, say, Flamingo Gardens Clinic compared to what is happening at Fleming Street Clinic. When we look at how the patients are being managed in terms of their high blood pressure, maybe we'll find that at Flamingo, their blood pressures are controlled, but at Fleming Street Clinic, majority of those patients may not have a controlled blood pressure. So we monitor the results across the entire Bahamas to identify any gaps in the care that is being provided, because we need every clinic to provide the care on the same level according to the protocol. Conduct biannual audits. So at present, we have started our audits for the clinic, and I also conduct supervisory visits. So it's one thing for us to be monitoring what is happening in terms of the patients, but also what is happening with the clinic itself. Because if the clinic does not have the necessary equipment, then the patient can't receive the quality care. If they don't have a working scale, if they don't have a glucometer, if they don't have O2 sat machines, then of course that will affect the care that is being provided to the client. So we monitor the clinical aspect and also the health facility itself and its capacity to provide care for these clients. Some of our key indicators. So we monitor closely the percentage of clients with blood pressure that's less than 140/90. And remember, I talked about audits a few minutes ago. So in our audit, we would look at all of the blood pressure for all of the CNCD clients, and we will monitor those to see how many of those have a blood pressure that's less than 140/90. We'll also look at the percentage of diabetics who will have a HbA1c that's less than 7. And we also look at hypertension and diabetes in terms of their cholesterol, because their cholesterol levels should be less than 100, and we want to see how many of our hypertensive and diabetics patient has a controlled cholesterol level. Now, this is a special concern to us, and that is related to the percentage of our clients that have had diabetic foot screening. And we are going to be looking at that also in our presentation this morning. We monitor the percentage of hypertensive and diabetic patients who are smokers. Why is that so? We find that there are persons who smoke tobacco have increased blood pressure. So when we do our interviews, we have to find out from our patients how many of those are currently smokers or those who do not smoke, because that will determine how controlled their blood pressure would be. Of course, another area of concern for us is their eyes. And most of us would know that a lot of diabetics would have blindness or glaucoma. And so we have to make sure that these patients have some eye screening done. And of course, we also is very concerned about our BMI. Looking to see how many of our hypertensive and diabetic patients has a BMI that is that is greater than 25. So that is of concern to us. But I've been saying CNCD, NCDs, but what exactly is CNCD? So by definition, CNCD is also known as chronic diseases or NCDs, and it is those diseases that come about as a result of genetics, environment, behavioral factors. And these diseases, as the word non-communicable means, it is not passed on from person to person. So Dr. Moxie talked about social distance this morning as it relates to COVID, but we don't have to worry about social distance as it relates to CNCDs because it does not pass on from person to person, but it does develop over a long period of time, hence the word chronic. So you don't just wake up in the morning and just say, okay, I'm a diabetic this morning. That took a long period for you to get to the stage of diabetes, or high blood pressure just develop overnight. You know, years of poor stress management, poor dietary control, obesity, all of those come together for you to develop hypertension. Many types of CNCDs that we look at are the cardiovascular diseases such as heart attack and stroke. We look at cancer, chronic respiratory diseases such as COPD and asthma, and of course, diabetes. But you need to know what is happening in the Bahamas, right? Why is that? Why is CNCD important to the Bahamas? And it is estimated based on the 2005 Ministry of Health survey that 37% of the population has hypertension and 10% has type 2 diabetes. So almost 40% has high blood pressure and 10%, and that was 2005. So we could imagine that that number is much higher now. Some of the behavioral risk factors. So we look at, and I spoke about that earlier, persons who smoke tobacco or use tobacco. We look at persons who have little or no physical activity. We look at unhealthy diet, and of course, definitely harmful use of alcohol. All of these come together to increase someone's risk of CNCDs. When we think about environmental risk factors, we think about poverty. So we know that the persons who are poor or who are of a lower socioeconomic income tend to have unhealthy diet and have limited access to healthcare, and therefore tend to be the ones that have more of the CNCDs that we see. When we look at our metabolic risk factors, we look at those with raised blood pressure, obesity, high blood glucose, and of course, fat in the blood. A major concern for us in CNCD is the relationship between COVID and CNCDs. What we are finding, or what was found early on in COVID, was that the persons with the poorest outcome or who were dying were the patients that had comorbidities. Those persons with diabetes, heart disease, high blood pressure, those persons with respiratory diseases and cancer. So it is important for us to integrate a protocol for CNCD in our COVID protocols. And that's very important as we continue to manage our COVID pandemic. I just want to share with you a little bit, and this is available online. Dr. Sands, when he was the Minister of Health in 2019, based on the STEP survey, and you can look the STEP surveys up, it's available online. It's done every 5 years by the Pan American Health Organization and the Ministry of Health. And what they do, they surveyed 3,840 Bahamians between the age of 18 and 69 in the islands of Abaco, Cat Island, Eleuthero, Exumo, Grand Bahama, Inago, and New Providence. And you will see in yellow highlighted what Dr. Sands said. The Minister of Health, Dr. Sands, today announced the initial findings of the STEP survey, and the results confirm that the Bahamas is an unhealthy nation. That is a very strong statement. Our risk for premature death, disability, and health complications due to CNCDs continue to be high. So that is why CNCD and what is happening in terms of the management of these patients is so important. This was just 3 years ago. And we know that these numbers could very well be even higher in terms of the results that were found in the survey. So we need to work together to change this from an unhealthy nation to a healthy nation, because the health of the nation, of course, is the wealth of the nation. So what are some of the things that they found in the STEP survey? They found that 30.2% of Bahamians do not get sufficient physical activity. And the average BMI for most of us is 29.8. It says that 43.7% of Bahamians have a BMI greater than 30. And 4 out of 10, so there are 19 of us here, including myself, yeah, that's 19. So 4 out of 10, or 38% of us, have high blood pressure, but we don't know. So we are walking around thinking that we're healthy, but we could have high blood pressure. And the reason we don't know is sometimes because we don't get our medicals done. So that is alarming. I found that very alarming for us. 4 out of 10 walk around with high blood pressure and they don't know, and that can be very serious. But there were some good things that came out of the survey. They found that 45% of Bahamians actually drink the required 8 glasses of water, and 20% of Bahamians don't add sugar to their coffee or tea. This one was a little bit shocking because it said 70% of Bahamians believe they consume the right amount of salt. I think they take a little bit more, but based on the statistic, they say 70% do take the right amount, so that is commendable. Let us take a quick talk about that, look at diabetes. And I did not spend a lot of time looking at the definition of diabetes because as healthcare professionals, you have a lot of lectures and information on diabetes, so we just look at it briefly. So we know that diabetes is a chronic metabolic disease characterized by high levels of blood glucose. But what is amazing is that 422 million people worldwide have diabetes. The majority of those are living in low and middle income. And remember, we talked about the risk factors earlier. The environmental risk factors that persons who are poor or low socioeconomic income tend to have more of these CNCDs. But we also see that 1.6 million deaths are directly attributed to diabetes each year. And recently I read that in Jamaica, most of the deaths that were COVID related, these persons had diabetes. So, and we know also here that a lot of the persons who were dying as it related to COVID was because of the CNCDs. So what are some of the criteria for screening for diabetes? So in interviewing your patients, and you interview those persons and you realize that they have a strong family history of diabetes. These are the persons who need to be screened annually. So they should be on your high risk monitoring list, those with gestational diabetes, those with a waist circumference greater than 40 for men, and those with 35 for women, those with a history of vascular disease or high blood pressure, and those, of course, who present with some impaired glucose reading when they show up at the clinic. So we at the clinic should have some way through the medical records to monitor these patients so that every year we screen them to make sure that they have not developed diabetes. But in order for us to diagnose someone with diabetes, we look at symptoms of diabetes plus a random blood glucose that's greater than 200, a fasting blood glucose that's greater than 125, and a 2-hour blood glucose greater than 200. So if someone comes to you at the clinic and they show up for the first time, they get a finger prick done, and their blood sugar is pretty high, greater than 200, you don't diagnose them with diabetes right then. Do you understand? You would need to have these patients come back and have a repeat fasting blood sugar done and the HbA1c. And based on those results, along with the symptoms, these persons would then be classified as diabetic. So that's why it's important when these patients with diabetes come to us because of the nerve damage to their feet, we have to ask them, shoes and socks, take them off. So every time a patient comes with who is diagnosed with diabetes, it is the responsibility of the doctor and the nurses that are assigned to ensure that we encourage the patients to take off those shoes and those socks so that their feet can be inspected. So shoes and socks, take them off. Diabetic foot screening. Has any of you have done any foot screening in terms of diabetes as yet? So what we do is at Flamingo Gardens Clinic, at Elizabeth Estates Clinic, and at Fleming Street Clinic, we have nurses assigned to diabetic foot screening. And in my hand, I'm holding what we call a monofilament. Sorry, I didn't have the picture, but it's right here in the diagram. And what we do is we perform regular inspection and examination of the diabetic foot, identifying those at risk, and then we educate the patient and the family and advise them about proper footwear. So nurses are there at the clinic. They perform these assessments on certain days. So once you're assigned to the clinic, you can always ask about the diabetic foot nurse who is at the clinic, and so that you can see how she does the foot screening. And all these areas on the chart are assessed. What we use is the in-low 60-second foot screening, and we look at the skin. So we want to know, is the skin intact and healthy? I won't go through all of them. We look at the patient's nails, because you know there's a proper way to cut their toenails. We look at the sensation, because we're going to know whether or not this patient is having some sort of nerve damage. And we do both feet. We also look at their pulses. So we want to know if the pulse is present on both sides. We also observe both sides for both feet for deformity and range of motion. And of course, the last area that we would look at is the type of shoes that they're wearing, because the type of shoes that they wear can put them at greater risk for developing ulcers, which can later lead to amputation. Once they would have done the foot assessment, they are then referred to the podiatrist. And presently, Dr. Danny Johnson is the podiatrist that works with us. And podiatry clinic is held at Elizabeth Estates Clinic and at Flamingo Gardens Clinic every other Thursday. Patients who are at low risk, they don't need to be referred to podiatry, but patients who are at high risk and moderate risk, they are referred to podiatry, and they will be seen by Dr. Johnson. This is what the referral form look like. We write the patient's name, date of birth, the demographic information, and the reason you are sending this patient to podiatry. Another area of concern for us as it relates to high blood pressure and diabetes is depression. So all our diabetics and hypertensive should have some depression screening done. And if the first answer is no, then you don't need to continue. But if they're saying yes and yes, then you have to continue to that through the entire questioning. And of course, if they have 3 or more, then this person may have some depressive disorder, because if the person is depressed, they're not going to be taking their medication as they should. And so it also affects how they eat. So you have those who may be depressed and they eat a lot, and then you have those who are depressed and they don't eat. And of course, diabetes and food, you have to monitor what you're eating. So therefore, if they're depressed, we need to make sure that we screen them and get the necessary help. When we look at hypertension, we look at sustained abnormal elevation in blood pressure. And the fact sheets for this states that premature death worldwide is 1 in 4 men. How many men in this class? Now we have 22 persons. So 1 in 4 men and 1 in 5 women, over 1 billion persons having the condition, right? So we have to be careful, because we learned earlier from the STEP survey that 38% of us are walking around with high blood pressure and we don't know. So, and you know, we call diabetes and high blood pressure the silent killers. Once the person comes to the clinic, again, just like with diabetes, you don't just diagnose them as hypertensive from the first time they appear at the clinic and their blood pressure is elevated. These patients must be asked to return to the clinic and their blood pressure checked at least 2 more times. And if it's elevated above 140/90, then they will be considered hypertensive. So it's not the first reading, it's not the second reading, at least 3 readings of greater than 140/90 on 3 different visits. So not the same visit, before this person can be diagnosed with high blood pressure. But we have to make sure that we are taking the blood pressure according to protocol, making sure they're sitting properly, making sure that our blood pressure machine is calibrated properly, and that we're using the right size cuff, because all of these will affect the reading that you get. Some complications include aneurysm, stroke, heart failure, thickening or narrowing of the blood vessels, and dementia. And of course, the last CNCD we look at is asthma. And when we look at asthma, we know that asthma is a condition that affects the airway. And this can affect how the person breathes and causes that wheezing sound. We look at the person's O2 sat. So every person that has asthma, once they present to the clinic, should have their O2 sat measured. And of course, we know the normal is 95 to 100. If someone comes to your clinic and they're at 80, we have to run. This person is in critical condition. And that's what we're finding with our COVID patients. Their O2 sat drops very, 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 very low. Some of the complications as it relates to asthma is fatigue, frequent visits, and of course, absence from work. You may not be able to see this form properly, but I could have it emailed to you. But this is what we use with our children under 12. And we ask them when they come to the clinic how they're feeling based on their asthma, if it affects how they go with their activities throughout the day, and throughout the night when they sleep. This is the form that we use for adults. So of course, we want to know in the last 4 weeks, how much of the time did your asthma keep you from going to work? So they'll tell you, nurse, I haven't been to work because I wasn't feeling well. I was just wheezing. I've been off from work for a month. So all of that we would document on this chart. And once the patient's score is less than 19, then we would say that this patient's asthma is not controlled. So every asthmatic should have an asthma control test done, but we need them to be greater than 19. We need their score to be greater than 19. This I will also email to you so that you'll be familiar with this form, and it is used at the clinic for all our asthmatics. Now I've been talking for a while, so now it's time for you to get some physical activity. What is CNCD without physical activity? So those of us who can, please let us get a little bit of physical activity in as we continue this brief presentation. Are you ready, everyone? Is everyone ready?
We're ready.
Okay, let's go, because you had a meeting first thing this morning. Now you have another meeting with me and more meetings today. And you've been sitting, so let's stand, everyone. And let's get some activity in. Let's go. Are you moving, everyone? Up. Awesome. Did everyone enjoy that movement? I didn't hear you all. Yes, ma'am. Thank you. So actually, every 45 minutes of sitting, you should actually get up and move. So those of you who have a fitness watch, you should time it so that every 45 minutes that you're sitting at your desk, you get up and you do some sort of movements. Exercise your legs, your arms, go outside, get some fresh air, take the mask off, and just get some exercise going every 45 minutes. Okay. Now my screen doesn't want to move. Okay. So last thing we're going to look at is just your role and responsibility. What is expected of you when you see a patient with CNCD? Of course, we know to continue to be professional, you know, to adhere to the policies, to have a commitment within yourself that you're going to do everything possible to improve the quality of life for that patient. So if it means that you're going to, you know, have a discussion with them about their diet, their exercise, about their stress level, if it means taking a couple more minutes, a little longer than you should, or that you can spare because the clinic is sometimes so busy, but just making sure that we give the attention and care that we need to all of our CNCD patients. When these patients present to the clinic, they should have their temperature checked. And now that we are getting back to some normalcy, because right now within COVID, we're finding that our CNCD patients are, one, they're not coming to clinic. They're just presenting for prescription refill. They're not having their routine labs assessment done, but we are trying to work with the clinics now to get all the patients back into clinic, or CNCD patients back to their healthcare provider to be assessed. And once they present to the clinic, they should have their temperature checked, their pulse and respiration, their weight, because we need their weight and their height in order to calculate their BMI. We are now going to be doing also their waist circumference. So now we have our tape measures that are going to be at the clinic, and we're going to be doing their waist. We're going to be looking at their dietary pattern and their nutrition. We need to do their finger stick. If a diabetic comes in the clinic, we need to know what their blood glucose is. And of course, we need to make sure that we perform a urine test on these patients. Are they spilling glucose? Are they spilling protein? Are they spilling, is there leukocytes? Whatever it is in their urine, we need to know so that we could provide the quality of care that they need. We also have to ensure, and one of the things that we are auditing for is documentation. Because we know in health, if it's not written, it's not done. So once these things, once the blood pressure is done, the blood sugar is done, once the waist circumference is done, if it's not written in the notes when we audit, then we assume that it was not done. So all of these things must be documented. We need to document the patient's diagnosis. And we need to, of course, document what medication the patient is on. Hopefully soon, we should be getting our electronic medical record system. I know plans are on the way for that. And also very soon, we have started discussion for the Hearts Initiative, with the Pan American Health Organization. And of course, that will be launched very soon in the Bahamas. And so therefore, it is important that all these assessments are being done on the patient. We need to make sure that we use all those screening tools that I just showed you. We have to make sure our patients have an ECG done. Our hypertensive patient must have an ECG done at least once per year. And then we have to make sure that they have their labs. I know presently there are some clinics that have challenges with having blood tests done. And we're working to provide portable machines, and maybe, especially for the family island, to have the team of phlebotomists and ECG persons go down to the islands to provide the services to those patients, because we should not only limit the services to New Providence. Every person throughout the Commonwealth of the Bahamas should have access to the same quality of care. Don't you agree? I'm sure you do. We have to make sure that these patients have their lipid profile and their serum creatinine levels, because we know renal failure is a serious concern for us with our CNCD patient. But it is okay to write the form, but we have to make sure that the patient have the test done. We have to assess whether or not this patient might need some counseling. The patient might need to be referred to the dietitian. So if I come to you and my BMI is 43, I am 250 pounds, then you need to have a conversation with me. You know, Nurse Med, I think that you need to see the dietitian. I'm going to write up a referral for you. And at present, our dietitian are seeing the patients via Zoom, so the service is available. And I cannot stress it enough that every patient that has diabetes must have their foot inspected or assessed by the foot assessment nurse every visit. So inspection is every visit, but the foot screening is as based on their scores. Follow-up appointments. And I know we do very poorly as it relates to CNCD, but we need to follow up these patients. Once they're given an appointment, we need to make sure the patient comes back. We need to see how they're doing on those blood pressure medication. We want to see how they're responding to the asthma medication. We want to see how their diabetes is. Is it being controlled based on the medication, so that it can be increased or decreased as needed. And of course, we have in each patient notes a CNCD health form, which you could glance at, and it should be completed by the CNCD clinic coordinators, and it just gives you a quick glance of what the patient has already and what is outstanding. So if you look at it and you notice, oh, this patient has not a cholesterol test done in 2 years. Oh no, I need to make sure this patient have a cholesterol test done. Oh wow, this patient need a HbA1c because it hasn't been done in a year. So this just helps you to tell you what is needed for that patient. But again, we have to work together to minimize not just the patient's risk, but our risk as healthcare providers. To eat healthy, to exercise regular, to decrease our alcohol use and decrease our tobacco use, and of course, decrease stress. I know that you're all in school, and stress is maybe a part of school, but managing that stress is very important so that you don't develop high blood pressure. Thank you very much. Any questions for me this morning? I am willing to take those questions.
Good morning, Nurse Smith. Just wanted
Good
to
morning.
know,
Good morning.
just wanted to know if you could speak a little bit about the eye testing in terms of diabetics. I know that it is a challenge, so could you just kind of give us some more insight into, you know,
Right.
some of the challenges and some of the interventions that you guys try and do given the limitations that exist?
Right. So thank you for that question. Because at present, we have our ophthalmic nurses, but because of COVID, they've all been reassigned. But we have been in discussion, at least I've been in discussion with Dr. Swan to see how quickly we can have this service available to our diabetic patients, because to get an appointment, say on Soldier Road, because I was there recently and I know a patient came and she got an appointment for next year, March or April or somewhere there. And we know that our diabetics need to be screened. So at present, we don't have an optometrist, but the Ministry of Health is working to see how quickly we could control our COVID situation so our ophthalmic nurses can be back in the back providing the services that this patient needs. But for now, Soldier Road is available, and I know there's one nurse at Flamingo Gardens Clinic, Nurse Gordon. She has been trying her best with her duties at Flamingo to provide some screening, and she for our CNCD patients. So that is where we are at presently, with as it relates to ophthalmology for our CNCD clients. Actually, up to last week, Dr. Swan and I spoke about that. So we're working on it as best as we can. So Soldier Road for now, Soldier Road, the clinic on Soldier Road is the only clinic available at the moment. And of course, Flamingo Gardens Clinic with Nurse Gordon. Any more questions for me, please?
Nurse Smith, in regard to that, I think we need to think a little more differently, and see if we can bring in the private sector. I know there's a cost involved, but either we pay now or pay later. That's what I always say with these things, because
That is really true, Dr. Moxie, because right now patients aren't. It's such a serious situation because one, they're not coming in the clinics to have their blood sugar monitored. It's been almost 2 years. Some of these patients have not been in the clinics.
Very serious. Yeah.
And all they have been doing, some of the clinics have been telling me when I even last saw on the Family Island is that the patients are just going for refill. So we don't know what condition or what state these patients are in. So last week we had meetings with the Pan American Health Organization because this Sunday is World Diabetes Day. And we are in the process of doing some PSAs to encourage patients to come into the clinic to be monitored by the healthcare providers. We are having discussions with the nurses at the clinic to call these patients to book an appointment for them to come in and stress the importance of having this monitoring done, because you can't just take medication for 2 years and nobody knows what your numbers are. So that is very dangerous.
Right.
So it is a serious concern.
Yeah, it requires sort of, sorry, go ahead, continue.
Yes, knowing that these are the patients that are dying, we really have to do more in terms of CNCD and the present COVID protocols.
Right.
It has to be integrated.
Right.
Sorry, Dr. Moxie.
And more resources have to be made available, It's like, where do you spend the money? Do you put it, into ophthalmology, optometry, or you wait till no, you don't even want to think of that. But,
No.
What I'm saying is you want to put things ahead, up front to prevent. That was always my mantra. Prevention is better than cure. And so you have to reallocate resources, and if necessary, bring in, say 3 more ophthalmologists from wherever, they're available to at least get a handle on the amount of people that have to have their eyes examined in a timely manner, or at a reasonable time.
Yeah, that is.
Other than that, I told the students, and here, Nurse Smith, you're confirming exactly what I said to them, because this general discussion came before, and I said it's months.
Yes.
Before you could get an appointment.
Yes.
Instead of maybe 2 weeks, wouldn't be too bad or something like that. I know there's queuing in all systems, there's queuing. In Canada, they have that problem too, where you can't get this and can't get that. Their system is similar to ours, their health system.
Right. Yes.
And they have the same problem.
Yeah, but I
But we know
also,
where the bottlenecks are. It's ophthalmology. It's been that way from the time I was NCD manager, at the Department of Public Health. It was always ophthalmology had the worst, sort of audit, that because the patients, there was no, space,
yeah, there always a
to get
long
a
waiting
reasonable
list.
appointment. And
Yeah,
that is years ago since I was NCD manager. And I'm,
it hasn't changed, Doc. Sorry to say, it
yeah,
hasn't changed much. Sorry to say.
but there has to be some focus, it's time to, as you would say, stop all the talking and some action, look at it holistically, at strategic level and say, what do we need? I remember the talk we were having and I gave a crazy number. I said, we need at least 20 ophthalmologists. And I think it was health systems talk. It was something we were doing. And I sort of went crazy. I said, we need at least 20 ophthalmologists for people to be seen in a timely fashion. Of course, I said, I don't have any data on that. I was just being a little, wild in my estimation.
Yeah.
Yeah.
But you are correct though, Dr. Moxie, because I even recently, Dr. Johnson shared an article with me where patients are presenting to the clinic now with severe complications because of not having any monitoring done for the past 2 years.
That's the
So,
foot clinic now we're talking, or the eye.
no, these were patients with different conditions, different CNCD
Oh.
conditions. He just
Oh.
shared the article with me. And
Oh,
so
okay.
that is what we should be mindful of in public health, that while we are trying to deal with one situation, we don't create another.
Exactly. Yeah.
So, we have to make sure that our CNCD patients, when they present to the clinic, that they still have their blood pressure done, that they still have their urine test done, that they still have their fingerprint done. And if we don't see the patients coming out, make an appointment system so that they feel comfortable in coming to the clinic, because everybody, because of the COVID, is afraid to come out. But we need to find a way to get them back into being monitored, because the outcome is even worse.
Yeah.
Yes.
A safe way, you have to reassure them that it's safe to return to the clinic. I think that's a general message that can go out. That is now
Yes,
safe.
that's what we're working on recording this very week. Yes.
Because people, have to feel comfortable that they're not going to catch COVID in the clinic, which could kill them. So, that's a reasonable fear.
Right. It is.
So I think it's a tug of war. They may want to come and then the COVID fear hits them, and they said, oh boy, I'm not going in there because somebody may have COVID in the clinic and give it to me. And it was the same thing at PMH in the earlier part of the epidemic or pandemic. When I had patients who I wanted to refer, and that was the first thing they would say, oh, I don't want to go to the hospital, And so, you'd have to convince them you have to go because, the risk of COVID is not, was low and, but your condition demands immediate urgent attention. So it was a choice you had to make,
Yeah.
Yeah. So that came up over and over in my practice where people were afraid to go to the hospital. But a clinic is a more step down setting. I mean, I don't know.
Yeah, I guess they consider that, listen, the COVID patient is more likely to be at the clinic than at the food store. Or the COVID patient is going to be more likely, there than wherever else they would go. So they'll go to the other places, but they'll avoid the clinic.
Yes.
So what we would do in our PSAs that we're working on is to show the precautions that are in place, so that they realize that there are safety steps that are in place to make sure that when you visit the clinic, that you are there for just what you came for and you don't leave with anything else. So,
right. Yeah.
Presenting that to them in a way that, change their mindset, because even with CNCD, it's about lifestyle. It's about behavior modification. It's about changing social norms, how we live, how we eat, how we think,
That's true.
And so
the social determinants of health, when you were talking about the environment,
and
it's the same as the social determinants of health. The environment you're in is, you could describe it in that way too. But,
And
you
the
know,
challenge we have is that obesity,
right,
it is a major issue for us.
correct.
But the social acceptance of obesity is more like if you're not a certain size or a certain weight,
Mm.
then something is wrong with you. And then of course, you know, we have persons who, even when they don't feel well, they would just monitor situations at home and then present in a very ill state. So we want to make sure that the patients have information. What is diabetes? What are the signs and symptoms? What is high blood pressure? What are the signs and symptoms? And then one of our focus this year, as I speak with Paho, is that we want to look at children with diabetes.
Okay,
That is a
good.
major concern for us. You know, how many children do we have at present with diabetes? And so how many patients are being screened? Because I know recently I came across a young lady, she was only 13, and it was an incidental findings because she didn't come in for that. But what happened was when they checked her urine, she was spilling glucose.
Wow.
And lo and behold, when they did further tests, she's a newly diagnosed diabetic.
Type 2? How old is she? Oh,
She's 13.
oh, wow. So
13.
that's obese.
Yes. So, you know, and so we have to also talk to the parents. Of community awareness is important. When you
Right.
see these things happening in the children, you know, it could not, it's not just, oh, it's the teenage years or they're just going through a phase. Maybe it's something that you need to look at, because if you had diabetes when you were pregnant, if you have a strong family history of diabetes and your child is now losing weight and having this fruity breath and, you know, eating every minute, although we know parents are complaining now because the children are home for the summer, I mean, for a virtual, but we have to look at all the symptoms together and say, hey, no, this is more than just, there's something ain't right with this. We need to
Right.
get you checked out. So diabetes in children is a major concern that we want to monitor to see, you know, how many children we really have with diabetes.
Thank you.
And I didn't say, but our office is located at Fox Hill Clinic. So we have a small office here at Fox Hill Clinic, and we're here usually between 9 and 12 because the clinic itself closes at 12. But if you require any more information as it relates to any of the CNCDs or CNCD health forms, I will be more than happy to provide those for you.
Good. Students,
thank
any more
you again.
questions? Okay, no, I had another one. If the students don't have one, I don't want to take up all their question time. But you mentioned it's more a clinical thing. I just want to know how you'd get around this. So how, you know, the protocol states you get around it. So if somebody comes in with a pressure, say, of 190, 110, or okay, obvious, what I would call obvious hypertension. You
Obvious
would
hypertension.
say, let's push it up a little bit, 200, 120. Well, you know, that's a urgent situation.
Urgent.
You
More
would
than
sort of
likely.
refer as opposed to saying come back, or you would treat,
Oh,
because I don't want the
definitely.
students to get the impression that, okay, you come in once, okay, it's how you come back, you know.
No, most
So I'm trying to
definitely.
put in their minds, you know, that it's a flexible system. It's not always cookie cutter. Well, you must come in 3 times before we diagnose you. You know.
No,
So
no, no.
talk to that notion, you know.
Okay, so our recommendation is if the blood pressure is 120 to 139 over 80 to 89, these patients should be monitored every 6 months. So if their initial visit, they're between 130, 120, 80 to 139, 89, they can be monitored every 6 months. If they're between 140, 159 systolic and 90 to 99, those are the patients you confirm on 2 other visits. If they're greater than 160, 100, they confirm on 2 other visits within 1 month and initiate drug therapy. If they're greater than 180, 100, confirm BP in one other visit within 1 week and initiate drug therapy. And of course, if the diastolic is greater than 100, then you would diagnose on a single reading and initiate drug therapy. And all of this is available in the hypertension guidelines, which I could also email to you.
Good. Yes. Okay. I want to, to have a sort of more informed approach to it. No,
Yes. I thank you
thank-
for that, Dr. Moxie. I did
Yes.
not go in detail with that part. I'm sorry.
Right.
Yes.
Yeah.
But
We
very
have
good
time. I mean, but I
question.
know you have to get on with your day, but you still have time because you had a 1.5 hour slot for the same reason, that I know it's a lot of details.
And one of the things that the students can also start to look up is the Hearts Initiative. The Hearts Initiative that on the Pan American Health Organization website in the management of cardiovascular diseases. There's actually a hearts course that's available on the website. I will have to send you the link, Dr. Moxie.
Okay. And to the students directly. Send everything to them at the same time because
you would be sharing their emails with me, or they were
they're the class email.
Okay.
So send it to both the class email and to me.
Okay, awesome.
I like them to get it at the same time, because it helps.
It
so
does.
Their email is MCH from Mona Cahill, MBBS for the degree and 23 for the year of graduation. So it's mchmbbs23@gmail.
Okay.
So you could share. Now, what about the presentation? You'll be able to share that too?
Most definitely, Doc.
Okay, great. So you can send, to both, excuse me, both of, the two emails, please. That'll be very useful. Thank you.
Yes, sir, I will. And of course, we have to document, we don't document a lot in the patient's notes when we talk to them about their diet or their activity levels, but these are some of the indicators we look at. So it's good to know that whatever it is that you discuss with the patient, you make a documentation in the notes that you spoke with the patient about, eating healthy or going for exercise. We need 30 minutes, 4 times per week is recommended. And you don't have to sign up for the gym, just regular walking in the afternoon. And if it's a talk about reducing stress, then you also document. So documentation is really, really, really important as it relates to CNCD. If it's not written, it's not done. And so when we audit and there is no documentation of these patients having any dietary counseling, we will have a talk again with the physicians to say, please document, so on. And one of the things that is also important is that when these patients present to the clinic, it's important to monitor the previous history, their previous visits. So if the patient came in and they were 100 pounds and then their next visit, they're 120, and you notice these numbers are going up, have that conversation with the patient. If their first visit, the blood pressure is, is normal, then it starts to go up, have that conversation with the patient, about lifestyle changes. And sometimes it's as simple as some of the things that the students wrote, getting enough rest, making sure that you decrease stress. And those of us who have, a really good social life, we have to make sure that you don't, take too much alcohol. And those who smoke, to make sure that that the more you smoke, the higher your risk of high blood pressure. And so if, I think that even though we are stressing about patients, we also need to take care of ourselves too.
That is true.
And I think
in fact, yes, the students are doing a study on mental health in healthcare workers as their project for the clerkship.
Okay,
Yeah, I read the proposal. It's very good, and it's going to be very useful, when they complete it and they're able to present and publish. And
I would
so
love
that
to
should
read it.
give,
Yeah.
yes,
Once
okay.
it's published.
So students make a note to share the study with Nurse Smith. I'll make a note too.
Yeah.
I'll find out about when they're presenting, and I'll ask the other tutors if I can invite, well, the other non-UWI tutors, because we did it with the last group, but I'll see
Okay.
what they say for this group and
That's
invite you,
awesome. Yes, Doc. It's important because we don't do the best we can, and I don't have the statistics, of how many of our healthcare providers have CNCDs, but
Mm,
that's something else that we probably need to look at.
right. Did you, just a quick aside on that note, did you mention depression screening? I was away from the phone.
Yes,
I
so
mean,
we did go through
okay,
the depression screening and its effect on
okay, good. Okay, I was doing something for a minute, I think.
yeah, right,
Okay,
right
good.
there. Yeah, we did look at the depression screening, which is very
Oh,
important.
yes. Okay.
Have you been feeling
I'm
down,
feeling down,
depressed,
or you're bothered,
hopeless,
but
hopeless in the past month? You know, and
good.
and and COVID has
Yep,
other additional challenges.
yep. On top of the regular life challenges, it's really
It
something.
it'll be interesting to see how it is affect our obesity rate.
Well, I think it's gonna go up because even me gained weight.
I think
Because
it's gonna go up.
I wasn't doing much exercise before, but definitely all the lockdowns, you just didn't, you didn't plan to do anything because you were, told to stay home. I
And
mean,
the
you could
first
exercise at home. There was no excuse for not doing something in your yard,
yeah, get up and
that
move.
kind of thing.
Yes.
Um, so let me see. I have some more questions. Students, anybody has a question? We still have a little time. Let me see. We've been here an hour and 12 minutes. So anyway, I'll ask my question. So what is your connection to the Healthy Bahamas Coalition? Why I'm asking that is, I know they're looking at the highest level of population, prevention strategies. So, which obviously affects what you would see at the program level. So I know you can't do everything at a program level, and that really is the responsibility of the Healthy Bahamas Coalition to bring in the business community, the civic, civil society and government to tackle the problem at the highest possible level. So, and as you brought up, you said, we have a huge problem with obesity, and we do live in an obesogenic environment, just to throw that concept in. So how do you all relate to the Healthy Bahamas Coalition program?
At present, I have not had any meetings or discussions as yet. What I have been working on is setting up our multidisciplinary team for CNCD.
Okay.
So what we are trying to do is to set up our terms of reference for each of the persons that are going to be a part of this team, because we know
Right.
managing CNCD is not a one-man
No.
situation. So
No,
we
you're
have,
right.
our NGOs, our non-governmental agencies, and
Yes.
then we have the Ministry of Health all working together for one
Correct.
cause, which is reducing our unhealthy
Yes.
situation that we're in. So I have just started discussion with our program coordinator, Dr. Swan, looking at
Okay.
our terms of reference, and then we are hoping to, in the new year, start our multidisciplinary team meeting, which includes key persons like the Healthy Bahamas Coalition, PAHO, Bahamas Diabetic Association, um, different partners as it relates to CNCD, but not just
Okay, cool.
diabetes. So,
Right.
of course, definitely nutrition and our ophthalmology team, everybody coming together, podiatrists on a monthly meeting to, because it's okay, some persons in one area working and the other area working, but we need to come together and
Correct.
work as a team in
Right.
order to actually bring about the change that we need to have happen.
Right.
So we are hoping to
Yeah,
have
there's
those meetings started soon,
right.
Dr.
Good.
Moxie.
Good. Now there's historical precedent for what you're doing. When I was there, we did have a multidisciplinary planning team for each of the same areas, cancer, hypertension, diabetes, asthma. And we did a lot of work. Now, I don't know if that's fully documented up there, but I suppose the files should still be there on what we did. If not, I have a lot of old material here.
Okay,
I guess I
awesome.
need to start to organize and share with you all if in fact, they don't have it up there now. But it was, I was more the focal point for diabetes. I had Dr. Holder for hypertension.
I remember Dr. Holder from Family
Right,
Medicine.
right. And who was cancer now? Somebody. Is it Turnquest? Yeah, Theodore Turnquest. I think it
Okay,
was the first back. And then what's the other one? Heart disease. I don't remember, but we tried to, do this we did have a multidisciplinary team. And we did have plans, to bring all this forward. And but the main one that moved ahead was diabetes. And then at the clinic level, we did have a team at the clinic level, and we would have the diabetes clinic at a different clinic on a different day. So, but Flamingo was a lead clinic. That's where I was, and we had the podiatrist, obviously the doctor, the nurse.
the nurse and the
The
team
nurse
there,
would double up as a diabetes educator.
nurse educator.
Then we had the key person was Mrs. Adelma Penn. She was, Penn, she's went back to Roche now. And she was a nutritionist, and she would have a 5-week course in
Course for the
nutrition.
person, right?
And they would take the person with diabetes through this course. And, I would do the checks. Podiatrist would come to the clinic. It was Dr. Stephen Dorset, also the late Dr. Stephen Dorset. And
Okay,
he would come faithfully, every week and examine people. They had appointments. And
right.
they didn't have to see the physician every clinic. They could be coming
No,
just for the podiatry. They could be coming, for the nutrition talk. So we did it like that, and we got excellent results to the
I'm
point
sure
where,
you could.
yeah, we did very good. It could have been better, but we did an audit and we went, PAHO did a survey when
Okay.
Dr. Van Rich Charles was here. And I think at the Diabetes Research Institute in Miami, where we all presented country findings. They did the analysis and, they
Okay.
presented, and we did quite well, with the same thing you're doing, the audit of foot examinations, ECGs, eye examinations, because we had a focus. And then you see that sheet in the protocol, the checklist,
Yes,
that's in the diabetes protocol, right? I originally designed that because I realized that it was so much to remember. When
right.
someone comes and nobody, no one doctor or nurse could remember to check all
Remember
these 10 things.
everything
So
that
we
needs
came
to
up
be
with,
done.
right, we came up with that idea and that worked. You could see, the ticks going across. This was done, that was done. You don't want to say it's cookbook medicine, but it's just a memory aid and a way you could record
It
what you're
really helps,
doing.
though,
And it's
Doc. It
very
really
useful
helps.
for auditing.
Yes.
Right. And you just saw those numbers coming down, as people came back, weights, sugars. And it was a clinic away from the general clinic. That's the other important thing, that the
Right.
person with diabetes, hypertension should really be in just what you're doing, the
Practice
NCD clinic.
NCD clinic.
as
A lot has
opposed to this
changed, Dr.
general,
Moxie,
right,
especially with COVID. So we're trying to, like I said, get back to making sure that our focus is on our CNCD patients and having them have
right,
their necessary assessment done. And,
back
you
under
know,
control,
because,
right?
yeah, because they're dying so
So,
young.
right,
Yesterday when I was at Fleming Street and I looked at the we were getting the list together, and these are persons 35, 33, 39,
my
and
boy,
some are
yeah.
already with amputations and
Oh
ulcers
boy,
and
sad.
so
We have to do something, boy.
yeah, we have to, and I am glad that we are getting closer to the point of COVID management where we can, you know, get our patients managed or how they are supposed to be, back in the clinic setting,
Correct. Right.
so
Yeah.
that will help us a lot because,
Right.
those,
Did you all ever use yes, Did any telemedicine was done in this time? Because that's a strategy,
there
well, the
was,
only strategy
yes,
you can use in a
most
lockdown
definitely,
situation.
most definitely,
Good.
most
That
definitely
was
that
good.
helped.
So, yeah, because all of the students is what we call the chronic care model, where it's a team multidisciplinary approach, this kind of thing. So that's the concept that we're teaching, the chronic care model. Okay, so I
I think
have another question, but anyway, I don't know if the students. Oh,
I
Miss
see
Wallace has a
Ms.
reaction.
Wallace has
Okay,
her hands up.
okay, and then I'll come back in. Thank you, Miss.
Okay, I
Okay,
don't have a
Dr.
question.
Moxie.
I just have a comment or a suggestion, if I can say that. So I would have transferred from UE Cave Hill, that's in Barbados, and I would have been involved in some of the nonprofit volunteer organizations there. And they have a really good initiative in November. I mentioned it before in this class, but with a different speaker. And if you have not heard of it, I would want you to please look it up and see if we could bring it to the Bahamas. It's called No Sugar November.
Can you repeat the name for me, please?
No Sugar November.
Oh, no sugar in November.
It's
Okay.
called No Sugar November, and it was started, I think, in 2019 by actually a reporter really highlighted by local parliamentarians in Barbados, even Prime Minister Mia Mottley, and then the World Health Organization actually highlighted it. So now they do it every November, and they challenge the community through like a 3-tier system to not to lessen or to completely eliminate extra sugar from their diet for the month of November.
Okay.
So I think that's a really good initiative that we could bring to the Bahamas if it's possible.
That's something that definitely we could look at.
Yes, ma'am.
And definitely have to do more research on it to see, what their results were, the indicators, their objectives, how it's set up, and how they were able to monitor their results from that. Because most of the events that we would plan, we would like to see what the outcome is, based on that activity. What do you know what their some of their outcomes were?
I'm not sure. I feel like it was more of a community challenge to get everybody involved in it. So you would see like a lot of persons using it in hashtags, and you would see persons on jobs challenging each other to see if they would meet the different tiers. So they had like gold, silver, and bronze to see what you could do for November.
Okay. That'd be
It was
good to,
more of like a public health campaign.
okay. I'll definitely look at it. I know for this year, our theme is access to care. If not now, when? And we're looking at access to care in terms of patient education, insulin, other machines and everything that is needed for diabetic care. So making sure that the patients have access to diabetic care. So that's the theme for this year for World Diabetes Day. I know in I think it's Berry Island, they have actually a challenge, a water challenge that they are planning for this month, where they are challenging their, similar to the no sugar challenge. I was just trying to look it up, to drink the 8 glasses of water
Yeah, that's good.
per day. I think that's one of the challenge. Let me see which island that was. Okay, so, right, so they have free bottled water giveaway, and then the challenge to have them drink the required amount. And then, of course, they continue with their education, but different clinics are having different initiatives for the month of November. So this is one that we could look at more, because of course, you know, decreasing the sugar intake is, but educating about, you know, not just the straight sugar, but reading labels, you know, reading labels. I was talking to the dietitian, and, you know, she said, when you go in the store and you pick up the ketchup, did you read it to see what it's made of? If it's high fructose syrup. And, you know, I don't ever really read the labels, especially on ketchup, but we have to stop and read those labels. Because sometimes, you know, it's not just the sodas and the sweet drinks or the sweet biscuits, but we also have to think of other items such as ketchup and other foods that they might have high fructose syrup in. But thank
Like, I
you
don't,
so much, Miss Wallace. That's I made note of it. Thank
You're
you.
welcome. And thank you for such a great presentation.
Oh, thank you so much.
yeah, just something like Vitamalt has 50 grams of sugar. I don't know if people realize that. It's advertised as a
Oh, your audio went out, Doc.
healthy drink, but it's a sugary drink with more.
Right.
Just to use an example of how, you know, advertising works, and you look at Vitamalt, you know, even the name Vita, Life, you know.
Mm-hmm. And I think many of us are misled a lot of times by some of these advertisements, or, you know, and I think labeling is another challenge that we have, and
That's true.
getting persons to, you know, read the ingredients that are on these things that are being bought. So having
Yes.
had the experience recently, I've had to go to dietitian counseling. You know, it opens your eyes a lot more as to things that you probably know, but probably didn't pay a lot of attention to, you know. But spending time to read the labels and not just picking something off the shelf because of the cost.
Yeah. Yes. Mhm.
You see, so we'll tend to just go shop based on the funds we have and not necessarily based on the health benefit that the food provides.
Mhm. But people say healthy food is expensive, you know. I've heard that reaction when you talk, you know, do some dietary counseling with
But it's
the
cheaper in
patient.
the
They
long
say,
run.
right, that's the way you have to promote it. You're right.
Yeah, it's
Pay
cheaper
now
in
or
the
pay
long
later,
run.
the same concept.
Yeah, that's so important, because what I say to patients, or I say to children, when I used to talk to children, is what you are going to be is what you're doing now. So, you know, based on how you're living, based on how you're eating, in another couple of years, that's what you're going to be. So you have to change what you're doing now. And like I said, I recently shared my experience of having to go to the dietitian because I have a 13-year-old whose BMI is, you know, up there, but he getting the young people to understand that, okay, we have to, for example, I stop buying certain food in the house and he goes, Mommy, you want me to starve it? You know,
Right.
Mommy, why we don't use white sugar anymore? We use the brown sugar. So for a while, he would when I'm away at work, he would make drink, with the sugar. But when I bought the brown sugar, he stopped. So
Good.
getting him to
I'm not sorry.
understand, getting him to understand that, you know, change is important, getting him to exercise and to get out the house, because these children today, they're into technology. So they don't move unless it's to change, you know, get another device to use or something else, you know. So we have to get our children up and moving. And that's a major concern in terms of obesity and leading to diabetes. I saw another hand up. I'm sorry. Who was that? I didn't see the name. The name went.
Oh, that was me.
Oh,
I was just, good morning, good morning. I
good
was just gonna
morning.
comment, I was just gonna comment on, you know, when person said that the food, the eating healthy is expensive, but I mean, now it's expensive, but before, I don't think it was expensive. Because they could
Back
buy
then,
like spinach was like $4 back then, like before COVID, pre-COVID. It was like $4 for buy the spinach. They could have just buy like two of that, that's $8. They could have had a $20 budget, literally, to buy vegetables. So for them to say that's expensive, that's just an excuse to me, in my opinion.
but what we also need to do, I didn't get the name again, is that we sometimes also have to encourage persons to grow their own garden. You know, the other day I went to Budget and they said $5 per pound for tomatoes. I went and I bought a pack of tomato seeds and I planted, you know, and I got tomatoes. I used the ones I got from the other food store. So sometimes it's also about encouraging our own backyard garden and to eat from the ground, you know, eat from what we grow rather than all of these processed food, because we have gone away from those backyard gardens, from, you know, eating bananas and sweet potato, and everything is fast food, you know.
Very unnatural. Yeah.
Yeah, so we got to get, and you know, the sad thing about it is we start the children from babies. So we're not encouraging breastfeeding. A lot of these babies are on these formulas, and as soon as they're able to take other foods, they're, you know, getting fries in their mouths, and they get in all of these and they develop the taste for it. So when we give them carrots, they don't want it, you know.
Yeah.
But we have to find creative ways to, from the children are very young, so that when, as they grow older, they don't develop these CNCDs. But thank you so much for sharing. And most definitely with the prices in the food store, if a parent or a mother has funds, she's gonna go and buy noodles, a couple noodles, rather than buying some broccolis and carrots and making a salad for the children. But we have to find a way to encourage people to eat healthy. And I think it's also partnerships with BAMSI and the local farmers to say, you know, make the price affordable so that persons can purchase it.
Yes, I
Wallace,
agree
you
with
had
that.
another question?
No, sorry, I didn't realize my hand was still up.
Okay. Go ahead, Miss Moxie, you were saying something? I thought Mr. Mox. Oh, that's Dr. Moxie. Somebody else was saying something a minute ago. So I noticed in the chat, some persons wrote what they would do, but I would encourage each of us to, you know, just plan at least one activity, one change that we are going to make to get our BMIs to a healthy BMI, less than 25, you know, at least out of the greater than 30, and try our best to stick to the plans that we make. So if we decide we're gonna go walking in the afternoon, and do it in a group if you can. Thank
Yeah, I
you.
told us, yeah, I told the students that the Ministry of Health itself used to have
The
an
exercise
exercise group
program.
that would go down to Fort Charlotte, I think just about every day or a few times, several times a week. And how there was a gym in the Ministry of Health itself. And that was ended up being used for office space, which was, not good.
Yeah.
Because the Department of Public Service came in and took, the other wing in the building that the Ministry of Health was supposed to be in. Anyway, did the gym did they ever revitalize the gym that's in the building?
No, so not that I'm aware of. And the exercise
Okay.
program, I don't think that's even going on anymore.
Right.
Sadly, we start so many initiatives and we don't, continue the programs long enough to
Yeah.
see the benefits from it,
Right. Yeah.
and that's
The
one of the
other thing,
challenges we have.
yeah. The other thing I told the students yesterday, now I don't know the tutorial it was in, was that we were looking at, we did primary care yesterday, and we were looking at how a clinic could be a lead organization for the community. That's what we were talking about, bringing in people from the community, either formally in local health systems or informally in a health committee or clinic committee. But we were talking about using the clinic itself as a place to exercise. And as a, I'm bringing in people and encouraging them, having a trainer or somebody to do that.
To-
Like
to-
how to do an afternoon exercise program or early morning. Once it's organized, it can happen because you have the facility there, the space,
The outside in the ground
Yes,
and so on.
outside is a big area there, and it sort of obviously is a good PSA for chronic diseases, for community involvement. Those kinds of values, are promoted when you have something like that. And I think it'll catch on because people could be screened, they could be given their exercise instructions, they could be weighed. It's actually a perfect setting because you have technical people, on the,
On there.
on your side, the clinic side, and then you have, I guess you need a trainer to come in, but we, that came up a discussion yesterday when we were doing primary care.
Yeah, I think what is the challenge, in my personal opinion, I find that we have somewhat moved away from preventative care a little, because we our focus should always be on prevention.
Yeah.
Early identification and risk management, risk reduction.
Yeah.
So, and I think we will get very far rather than spending, and that's one of the reasons behind our food assessment program. If we can identify early these patients with diabetes who have these nerve damage or are at risk for ulcers and addressing it early, then we could decrease our amputation levels.
Yeah.
And I think we have to continue to screen our patients. These numbers that we document tells a story, the trend, we look at what is happening with this patient. And so sometimes we tend, or I don't know if we spend enough time to even look at the old records. And right now, one of our challenge is continuity of care, because with some of the clinics closing, patients are being seen on don't have an actual file. So how do you monitor this patient over a period of time when there is no actual record, or the record isn't there? So there are some issues, and we're hoping with the electronic medical record system that we can, have some resolve to this issue. Because yesterday, for example, when a lot of the files, we had no medical records and they were just written on paper. How does this physician know what was done prior to? If this patient can't tell what their medication was, how do they know? So we have a lot of issues that we have to address. And then we also need to focus a lot more on prevention, education, education from within the school level, not when the persons are adults, not only, sorry, when they're adults, but let's start with the young ones, the little ones in preschool to encourage fruit and water, to have the system in the schools that say, you know, only these things within this mile of the school that can be sold to the children. I know at the hospitals, they were removing out of the vending machines, the sugary drinks. But recently I was at a health facility and there were sodas and
No way, that's not supposed to happen.
and all of these things. And I'm like, oh, that can't be because we have a system
No.
in place. So, but the problem also is that there has to be monitoring. So, you know, monitoring and evaluation of the system that's put in place to make sure that it is continuing and that it is working. I'm sure if we do a survey of the different vending machines, we'll see that some of them are going back to what shouldn't be. And so, you know, we have a lot of work to be done, and I'm glad that we have all these doctors that are in training, and we'll have the knowledge and the skills to help us to get from an unhealthy nation to a healthier Bahamas. And again, I am so happy to share with you all, and I will make sure that you get this presentation and any other information that you would require. Thank you again, Dr. Moxie, for the opportunity.
Right. I had one last question then, because I know you have to get the rest of your day started. On cancer screening, did you focus on how that is integrated into the program?
To be honest with you, cancer training has its own registry section. And while it's on the CNCD, it's not the area that we manage per se.
Okay,
Yeah,
I wanted to find out about that. Okay,
yeah,
good.
that hasn't changed. It's still a part of CNCD, but not under CNCD completely.
Right, yeah, makes
Yeah.
sense. Okay, because it's a
Yes, sir.
peculiar. Okay, fair enough.
Yes, sir.
Good. So, students, you know, we must thank Nurse Smith for really good, solid, comprehensive presentation and training in this area. So, she said there's lots of work to do in the area, and you know, we encourage you, as she was saying, to get on board this fight. You know, and it's not a matter of either or. You know, there are the infectious diseases. Of course, they get attention because they are a threat to life, and so, and reasonably so. You want to stay alive to, you know, manage your NCD, because if you don't make it through the infectious disease, you're not going to get to the NCD management. So naturally, and you know, you focus on these threats when they come around. But after that, after the threat is over, the infectious disease threat, you know, the NCD is still there.
Yeah.
And so you have to go straight into tackling that. So I think that's what's coming out of today's talk, you know. And in the old days, it used to be HIV. HIV took a lot of resources, and rightly so, because it was young people dying.
Right.
You know? And so the focus went to HIV in the 80s, 90s, and all of that.
Yes.
But now we have this other threat, COVID, you know. And it's the same battle again between, you know, for resources.
Yes.
So we hope that we get on top of COVID, and then we could continue with the NCD targets. And finally, you work with the Healthy Caribbean Coalition at all? Okay, because they also do a lot of good work and training, and they actually give grants for programs, you know, for activities, interventions.
Okay.
Also to different Caribbean countries. So that's worth looking up. I know Dr. Swan knows about Healthy Caribbean Coalition. I used to be a director for, you know, for 2 years because of my work with diabetes. I got invited through the Diabetes Association.
Okay.
And went to Barbados, you know, under Sir Trevor Hassel, Professor Trevor Hassel, and Maisha Hutton. So those are good resources for you, for
Yes, sir, I've documented that, and I definitely will have some
yeah,
discussion with Dr.
right,
Swan.
right. And you should join, you can join individually and students, please join also. Because they give good information on what they do. They gather all the activities of NGOs throughout the Caribbean. And so you get
Yes,
ideas. It's very good. All the islands are part of it. And including the Bahamas, there. Dr. Christine Chin. Oh, I'll end on
I know Dr. Chin.
Christine Chin is actually a director. Right. She's the team of the Cancer Society of the Bahamas, and it's to prevent childhood obesity. And so she's the president of that group. I'm in it. A lot of the medical students are in it from previous years. This group is welcome to join. And we work to focus on sugar sweetened beverages, that kind of thing, and physical activity in schools. Her husband
Definitely
gone to,
needed.
has gone to different schools and started backyard gardens. They've given out seeds for backyard gardening. And so they're well organized. They just had a meeting with the new Minister of Education. They visit schools, they do talks in schools, or we do talks in schools, because I'm part of it. Gambia, Adelaide, they've been to schools like that and they started gardens, I think, at Gambia and Stephen Dillard Primary.
Yeah, I think I
schools.
know about Gambia.
Right.
Yeah.
Yes, very nice garden. I saw pictures of it. But the thing is, as you say, the maintenance, keeping up with these things. So
yeah,
they need more people.
and starting with the young children,
Right, that's the idea. So they do the talks to the children, and work with them. So, that's a very good NGO that's doing good work. And as you say, tackling it from the early stages, from the early years, that both, talking to the children directly and also working at policy level with the Ministry of Education.
and the policies in place.
Right, to get into the schools, right. And encouraging, these things like what you're talking about, the good food in schools, and they even, but now this other thing with the sugar sweetened beverages on health facilities, that's really out of order.
Yeah.
Somebody needs to get that under control. But anyway, such is life.
Yeah, it's just about monitoring. We really need to monitor the programs once they're in place so that, they continue to do what they are supposed to be doing. So,
Yes.
Who is monitoring the vending machines to make sure that they are compliant?
Yes. What they need is to put a sign on the machine. So if anybody dares to put a soda in, they know that,
Or maybe, I'm not sure if there's a fine for these persons if they do put it in these.
Right. And getting to the company, itself, because the company managers or president should know that these are not acceptable. You're not gonna put, and then of course the administration of the health facility,
Yeah, that's important too.
Should really be monitoring. There should be, I guess you call it, they have a person, the risk manager or the.
Right.
In fact, there is, no, that's infection control nurses.
Students. Administrators are at the clinics.
Well, there shouldn't be any machines at the clinics, right?
They are at the clinics though. They are at the clinics because the machine I saw was at a clinic.
Hello?
They are at the clinic, Dr. Moxie.
Oh, I didn't realize that. Oh, wow.
Yeah, there are machines in the clinics. And that's where I saw one that I actually stopped.
You should have immediately protested, right? Immediately. That is insanity.
Yeah.
You're teaching weight, obesity management, weight control, and they giving persons in the clinic the sugar. Boy, no, that's unacceptable. There has to be a limit to the foolishness now.
Yes, we have to keep educating and re-educating persons. The same thing with CNCDs, education, continue education, persons are changing and different persons become in the different areas, and making them
Yeah.
aware of what the rules are and the protocols are.
Yeah.
You know,
Oh,
so
that brings up one final point. The front of package labeling, the black octagonal labeling, that's a new
I saw
thrust
that
now.
initiative, yes.
Right, so that Healthy Caribbean Coalition has been working hard on that throughout the Caribbean.
Yeah, I saw that drive to
Yeah,
make sure
so-
that these are placed.
Yes, so the students, they'll, the statement says this product is high in sugar, high in salt, if it's a salty thing. But that takes time to get that change, But that's a new movement, front of package labeling, the black octagonal warnings.
And I think it will help a lot because a lot of us don't read all those
Yeah.
ingredients on the things, on the items. And so, having that alert there will help persons to choose wisely.
Yes.
Choose wisely, because they say you want to hide something from someone, put it in writing. But sometimes we have to find creative ways to alert persons as to the dangers, that they're facing from what they're eating. What you're
Yes.
eating today, what you become tomorrow.
That's
So,
true. Yeah.
yeah, so. But yeah, I will definitely speak with Dr. Swan. And like I said, I started in July, so I am catching up to speed with all of
Yeah.
the different organizations and
Right.
NGOs
Doing a good job. Mhm.
myself. So thank you so much for the suggestions. Thank you for the No Sugar in November initiative. I would definitely look at that. And of course, the
Mhm.
Healthy Caribbean Coalition. So
And then this Caribbean Wellness Day, that's another thing that, is promoted. Dr. Swan is involved with that.
yeah, he's involved in a
Yeah.
lot of activities.
Right, I know he has his hands full.
Yeah.
So what's the theme for this World Diabetes Day? And you're having any
Access-
activities?
Access to care, if not now, when? And
Okay,
yeah, we are planning, we're gonna be recording several PSAs along with the Pan American Health Organization. And we
Yes.
are planning a health screening for November 26th.
okay,
Especially for our younger persons and our persons who are walking around who may be a diabetic and don't even know.
Mhm.
So,
Right,
and then we are also hoping to have with the partnership of the NASA agencies to ensure access to glucometers. So
okay,
there is discussion with them to make sure we have some glucometers available at the health screening. And
okay, good.
yes,
Yeah, all in the details.
yeah,
We used to
so,
have a massive health fair every World Diabetes Day.
yeah, but because of COVID, we have to.
At the town center mall, we don't have 2,000 people come through. It was again
Wow.
a demo pen. Yeah, would do it. There were some big thinkers in those days in the group.
Yeah, definitely. It sounds like it.
Yeah,
Yes.
learning class. I'll call you back.
Okay.
One moment, please. I'll come right back. Yeah, sorry.
Yes, I don't want to take up the other person's time.
No, there's nobody else right now.
Oh,
So
okay.
I was letting you talk because,
Yeah,
the
I
other
don't
person
mind sharing.
isn't coming in. Mhm.
Okay, okay.
So
Yeah.
I'm thinking too, this sugar sweetened thing in clinics, you really have to put up a sign. This is a no sugar sweetened beverage or no sugar zone,
No sugar zone.
something like that. This is a no sugar zone. Because you have to almost force your message out there because there's so many competing messages.
And that's the challenge, they're trying to make money But while we're trying to save persons' lives.
No, but not in the clinic. That is like
Yeah.
too much now. Please, that's like,
The contradiction of,
Yeah, no,
Yeah.
you can't be hypocritical. You saving lives in the clinic and you giving the people sugar in the clinic. No.
Yeah.
No,
Yeah.
money, I don't know. Maybe they should take these machines out and just have water in the machines. And that's it.
Possibly.
I don't know. The people can go down the road to get this beverage anyway, because the clinics are now right in the shopping areas. So it's no separation,
But at least they wouldn't get it at the clinic.
That's true. And you send a message, drink
Right.
water, exercise. Maybe you need to put, those messages up, and definitely no sugar sweetened beverages should be
And that's
allowed.
definitely one of the things we're looking at too, because most of the clinics have a television. And so we want to try to make sure that the messages are projected on the screens rather than some of the other things that I see on these screens while the patients are waiting. Now that the patients we're looking at getting back in the actual building, because at present we are screening patients on the outside. So
Right.
with COVID, it has changed the structure of the clinic. So when we get back into the clinic setting in the building itself, then using those televisions that are in there to broadcast the health messages, whether it's World Diabetes Day, and because while they're at the tent, you can distribute flyers and information. You could have a talk with them from a distance, but it's just a different setting outside there than when they were inside, and persons sitting down and they could be reading something. And so even with our foot assessment, we're saying when the patient comes while they're waiting to see doctor, make sure they have their foot examined and assessed by the foot assessment nurses.
Yes.
Making sure that we check these medical records to make sure that at least once per year, these patients have the necessary labs done. So we have to really monitor. And then of course, referral. One of the challenge I find also is that sometimes we do a referral for a patient, but is there a follow-up to see if that patient actually went?
Right.
And, so we need to have a system in place that says, okay, we have 10 patients for the dietitian. Did these 10 patients show up? Did we reschedule these 10? And make sure that, when they are referred, that they're actually seen.
Yeah, that's why I'm saying it's probably better, better use of your limited resources. I have 10 people come to one session. I mean, I know people need individual counseling. That's true.
Yes.
But I don't know. I mean, if you have limited resources, you have to think of another, a more efficient way to use the resources. So one dietitian could counsel 10 people at a time, and then I don't know,
maybe they could have, like a group session, and then have, because right now, like I said, they're doing via Zoom. So
well, that's even easier in a sense, because people don't have to come together from different homes,
Yeah.
That's a challenge too,
And I don't think we had talked about, the actual healthy diet and making sure our plates have half of it vegetables and a quarter is protein and a quarter is grains. But I think that's also something that we need to really look at, what our plates look like, and encouraging our patients to eat more vegetables. Exercise. Thank you again, and have a good afternoon, everyone.
You too. Take care. Bye-bye.